Hello everyone, I'm Yang Dejin from Beijing Jishuitan Hospital. I will now demonstrate the AVN bone model procedure. First, the patient is placed in a supine position. Here are the patient's head side, foot side, and surgical side. The surgeon stands on the surgical side, and the C-arm or G-arm is positioned on the same side. We usually elevate the patient's hips to neutralize the physiological anteversion of the femoral neck. This facilitates fluoroscopic imaging during surgery. Meanwhile, the entire lower limb remains in a free position. During surgery, I can flex the hip and position the leg in a figure 4 posture. This allows free fluoroscopy from various angles to ensure all desired tangential views of the femoral head are accessible. Before starting the surgery, we first perform surface marking on the patient. We usually place a 3.0 mm Kirschner wire or a guide wire in front of the hip joint. You can palpate the greater trochanter and estimate the position of the femoral head. Then position the guide wire accordingly and confirm its location under anteroposterior fluoroscopy. Make sure the guide wire's position matches the planned drilling direction and target. When selecting the target point, preoperative planning must consider the weight-bearing zone and the junction between necrotic and healthy bone. Generally, the necrotic area is located more laterally and anteriorly. The target is typically selected near the edge of the weight-bearing area. Ideally, it should not be too far from healthy bone and should remain within the weight-bearing coverage area. Because necrosis located more medially has a lower risk of collapse, stress concentrates at the femoral head adjacent to the acetabular rim, increasing collapse risk. Thus, support should be placed within the weight-bearing zone, slightly lateralized. If too lateral, femoral neck anatomy and channel length will limit access. After confirming the target and entry point, we proceed with lateral fluoroscopy. During lateral fluoroscopy, align the guide wire parallel to the original direction and pre-position it on the surface. Since femoral head necrosis is usually anterior, the entry point should be slightly posterior to the femoral midline. This facilitates smooth passage through the narrow femoral neck. On the lateral view, the entry point should generally align with the level of the lesser trochanter. If the entry point is too high, it becomes difficult to pass through the superior lateral part of the femoral neck. If the entry point is too low, the cortex is too hard to drill through and increases fracture risk. Therefore, it is generally best to select a point aligned with the lesser trochanter. During AP and lateral fluoroscopy, lower the hand position slightly so the guide wire points slightly toward the anterior femoral head. Since the anterior guide wire remains, you will see a single line on AP view and 2 lines on lateral view. Ensure the 2 lines are parallel and that an extended line would pass through the target point. After confirming the direction is correct, insert the guide wire percutaneously into the lateral femoral cortex. The lateral femoral cortex is angled relative to the drilling direction, making it prone to slipping. The guide wire and Kirschner wire must be single use to maintain sharpness. You can press the sharp tip against the periosteum before starting to drill. If slippage is significant, first drill vertically to create a small hole, then adjust to the desired angle. Once the guide wire is satisfactorily inserted, make a small longitudinal skin incision at the wire site. The incision should be about 2.5 centimeters long. After the incision, use a sharp blade to split the fascia longitudinally and then bluntly dissect with curved forceps. Insert the soft tissue protection sleeve carefully ensuring the three-part assembly stays together. After insertion, remove the inner sleeves, leaving only the outer soft tissue sleeve. There are two sleeve lengths. For thinner patients, the shorter sleeve can be used. For demonstration on a model, the sleeve can be temporarily removed. Once the guide wire is properly placed and the sleeve is set, begin creating the opening in the lateral femoral cortex. Since the lateral cortex is hard, it is recommended to first use a 7.5 mm hollow drill to expand the opening. Then use a 9.5 mm hollow drill to complete the opening. During drilling, rely on tactile feedback or fluoroscopy to ensure only the lateral cortex is penetrated. Avoid drilling too deep to preserve the cancellous bone in the trochanteric region. First use the 7.5 mm hollow drill to penetrate the lateral cortex. After feeling a slight breakthrough, stop drilling immediately. Then switch to the 9.5 mm hollow drill for further enlargement. Similarly, stop after penetrating the lateral cortex to protect the cancellous bone. A hollow ring drill was designed to harvest autologous bone from the trochanteric region. Now, we proceed to harvest autologous bone. After reaching a certain depth, it is recommended to reverse drill and then forward drill slightly to loosen the bone strip. Sometimes you can rotate while sliding to extract the cancellous bone. If done properly, a cancellous bone strip about 4 to 5 centimeters long can be harvested. The harvested bone can be soaked in saline or wrapped in sterile gauze for later use. After bone harvesting, proceed with formal drilling using the hollow drill. If the bone is very dense, a 7.5 mm hollow drill can be used first. If the bone quality is average, you can directly use the 9.5 mm hollow drill. During drilling, the primary principle is to avoid penetrating the subchondral bone. Fluoroscopy should be used to monitor the drilling depth. The drill has depth markings that can be compared with the sleeve edge to judge depth. Once fluoroscopy confirms the drill has reached the target, withdraw the hollow drill. Usually the guide wire will be pulled out together at this stage. At this stage, I usually use a syringe with a long needle to irrigate the channel. Irrigation helps to clear bone debris and blood clots. If necessary, a long-handled curette can be used to clean the blind end. Removing necrotic bone is not the main goal of the surgery. Small cystic lesions, if present, can be gently curetted. Then proceed with the tapping step. Use the combined tap and trial implant tool. The tool has a smooth tip and a threaded end matching the implant. During tapping, the soft tissue sleeve protects the entry path for smooth insertion. After insertion, gently move it back and forth to confirm it's within the channel. Rotate clockwise to tap and create threads in the lateral cortex. Significant resistance is expected. An assistant should stabilize the leg. Avoid deviating from the original channel direction during tapping. If resistance is high, advance and retreat alternately to tap progressively. After tapping through the lateral cortex, resistance will decrease. When reaching the subchondral area, resistance increases again. Resistance will spike when the tap reaches the blind end. Confirm the position with fluoroscopy or by referring to the tap's markings. Autologous bone grafting can be performed either before or after tapping. If worried about grafting affecting tapping, do it beforehand. Use the bone graft funnel provided in the instrument set. Place the harvested cancellous bone fragments into the funnel. Push the cancellous bone into the channel through the funnel. After removing the funnel, use the pusher rod to compact the graft towards the blind end. Then use the 9.5 mm hollow drill in reverse to compact further. This ensures close contact between the graft and the necrotic zone. After grafting is completed, implant the definitive prosthesis. The implant's length and markings correspond to the tap's measurements. Take care while inserting the implant into the bone channel. Ensure the soft tissue sleeve is closely aligned with the lateral femoral cortex. Avoid the implant deviating anteriorly or posteriorly. Once the implant tip enters the channel, it will lock into place. Screw the implant clockwise for smooth insertion. Use fluoroscopy during insertion to confirm position and direction. Resistance increases when nearing the blind end. Flex the hip and use fluoroscopy to ensure the tip contacts the blind end. Force can be controlled using a standard or torque-limited handle. It is recommended to use an 8 Nm torque setting. After implanting, irrigate the channel with a cannula. Clear blood clots to avoid residual debris. Fill the blind end with high-strength synthetic bone. Prevent synthetic bone from leaking into surrounding soft tissues. After thorough cleaning, remove the soft tissue protection sleeve. If needed, locally inject analgesics. The surgery is completed. Post-operative cross-section shows the implant reaching the blind end, positioned anterolateral in the weight-bearing zone. The blind end is filled with high-strength synthetic bone. This concludes the AVN cage bone model procedure demonstration. Thank you all.